Hello, I'm Heath Latham, and I'm a professor of medicine at the University of Kansas Medical Center. I have a passion for fluid resuscitation guided by stroke volume, and we'll be discussing today how we can look at optimizing fluid resuscitation specifically in our patients with septic shock, but also could even consider in any of our patients with critical illness. My only disclosure is that I have received speaking fees for Baxter Pharmaceutical, but will not be discussing anything off-label or experimental today, period. These are the objectives. Suffice it to say that overall we'll be talking about CMS guidelines or SEP1 guidelines for fluid resuscitation and septic shock, and then about mechanical and technological ways by which we could look towards resuscitation of our patients that are critically ill. So to start off with, for several years now, and almost over a decade, we've known that severe sepsis is a serious disease. And in fact, it is the number one cause of death in all hospitals across the world. And thankfully, it is now recognized as an emergency, and recognizing it and initiating our resuscitation is considered the gold standard to do so immediately. As a result of it being so deadly, it carries a very high mortality worldwide, about 27% of hospital mortality, and ICU mortality around 42%. Prior to the updated Surviving Sepsis Campaign guidelines in 2021, the need for or recommendation of resuscitation of everybody that presents with sepsis-induced hypoperfusion should receive at least 30 mils per kg of crystalloid within the first hour was downgraded from a strong recommendation with low quality of evidence to a weak recommendation with low quality evidence. I'd like to focus on our SEP1 guidelines that if you're a hospital here in the United States, you are required to follow these guidelines as one of the core measures and report this data to CMS. There's both a 3-hour bundle and a 6-hour bundle. And within those 3 hours, we got to measure a lactate, obtain blood cultures prior to giving appropriate broad spectrum antibiotics. And if the patient has evidence of hypotension or a lactate greater than or equal to 4, you're expected to give 30 mils per kg of crystalloid, unless you can document that these patients are at risk of getting that much fluid or are not fluid responsive. And then within 6 hours, if patients are hypotensive after the resuscitation, then we need to initiate vasopressors, reassess their volume status by a variety of mechanisms, and then remeasure the lactate if it was initially greater than or equal to 2. So where does this 30 mils per kg actually come from? There are no randomized trials looking at 30 and whether that's better than 25 or whether that's better than 35, etc. It is actually just some averaging. So in the 3 largest sepsis trials looking at early goal-directed therapy, Process here in the US, Arise in Australia and New Zealand, and Promise in the UK, ultimately what was shown was that somewhere, if you do the averages, about 30 mils per kg was given prior to randomization of these trials, and generally speaking, it took about 3 hours to recognize these patients, get antibiotics on board, and do the initial resuscitation prior to randomization. So this is where the original 3-hour bundle came from, and the 30 mils per kg that is recommended in our SEP1 criteria. So when you talk about averages, generally speaking, for all patients, overall, things will probably be fine if you do that 30 mils per kg, but some people got more, some people got less, and you could probably say some might need more and some might need less. So is giving the 30 mils per kg to all patients who present with severe sepsis or septic shock appropriate? And there are a multitude of clinical trials, mostly retrospective assessments that look back at this, and they all basically say that yes, it's safe to give it to patients that present with severe sepsis or that septic shock, and that they likely benefit from it. This publication by Seymour and colleagues is one of my favorite and what I often use in my discussions to say that bundle-based care can enhance care and is safe. So in New York, they have a registry, and every patient that presents with septic shock and the sepsis data have to be loaded into this database. So Seymour and colleagues looked back at this database of almost 50,000 patients at the time, and their question was, "D- does timeliness of completion of that 3-hour bundle actually contribute to better outcomes? And then was it safe in at-risk populations?" The primary outcome they were looking at was mortality, and ultimately, what was shown that in patients who got the 3-hour bundle, all of which got 30 mils per kg of crystalloid, the more timely that that 3-hour bundle was completed, the overall better outcomes did occur, particularly around mortality. And the strongest dependence of that improved outcome was the timeliness of antibiotics. But specifically, when they looked at risk populations of getting fluid, so those patients with a history of heart failure, renal failure, or chronic respiratory failure, those patients all did fine getting the 30 mils per kg. They did not have negative adverse outcomes from getting that fluid. And again, other similar types of studies have been looked at. And again, no adverse outcomes in these septic patients presenting that get 30 mils per kg. But the question is, does everybody actually need 30 mils per kg? So when we have a patient that presents with shock, for we should have particular goals. So whether we're treating any sort of disease process, we should always say that we have goals of our treatment, and shock is no different. So our first goal is to achieve an adequate perfusion pressure. We want to achieve a MAP to be greater than 65 millimeters of mercury. That way we can enhance delivery of oxygen to our key organs and tissues. We may achieve that goal by volume resuscitation alone, but maybe we need vasopressors, or in the case of cardiogenic shock, maybe we need inotropic agents. And then we want to improve our microcirculatory flow, which is just a fancy way of saying we need to figure out what the cause of that shock is and then treat that cause in the terms of sepsis. That means we need to recognize what the source of the infection is, get antibiotics on board as soon as possible, and then achieve source control. And then ultimately, we want to limit our tissue edema. And in limiting our tissue edema, that means that ultimately we only want to give the right amount of fluid, and we don't want to over resuscitate patients because that lead to adverse outcome. There have been a multitude of other studies over 20 years now. This by Cavallaro and colleagues, which was a meta-analysis looking at fluid resuscitation and whether or not they had improvement in their stroke volume or cardiac output. This is a meta-analysis of a multitude of trials, and ultimately what was shown that only about 50% of people who present with severe sepsis or septic shock that we would predict would benefit from fluid loading actually do have improvement in their stroke volume or cardiac output. That means about 50% of people do not have improvement in their stroke volume or cardiac output. That means that we will give fluids that likely will only ultimately contribute to tissue edema, which we don't want. We could spend an entire hour just discussing the potential adverse consequences of excess fluid in the critically ill patients, and specifically patients with sepsis or septic shock. And those outcomes can be mortality that are negatively impacted, or a multitude of other morbidities, such as time on ventilators, time in hospital, negatively impacted fluid and functional status. So we want to avoid that at all costs. So recently, a couple of large trials in sepsis have been published looking at a fluid restrictive strategies versus fluid liberal strategies in resuscitation of septic patients. Between these trials, both had about 1,500 patients. The classic trial was a protocolized trial, again looking at limited fluid volumes versus usual care, and whether or not those fluid restricted strategies resulted in better outcomes, specifically mortality. Multi-center randomized controlled trial in Europe was the classic trial, and it was an unblinded trial, and the primary outcome was 90-day mortality. For the Clovers trial, similar type of question, conservative fluid strategies, plus early interventions with pressors versus liberal strategy, and whether or not that impacted mortality. Again, this is a multi-center randomized trial here in the U.S., unblinded as well, and again, primary outcome was 90-day mortality. So in terms of the classic trial, initially patients were resuscitated with 30 mils per kg, unless that was thought to be detrimental to the patient. And then they were randomized to a restrictive strategy in which only additional boluses would be given in severe hypotension or evidence of severe circulatory impairment. And these boluses were limited to about 250 to 500 mils. Versus a more standard of care practice guided by the 2016 Surviving Sepsis Campaign guideline recommendations for fluid resuscitation. For the Clovers trial, it had a far more complicated protocols in the fluid restricted strategies versus the fluid liberal strategies. I won't go through all of these other to say that basically patients were resuscitated with 1 to 3 liters prior to enrollment. And then with randomization, they followed pretty strict protocols to either limit fluid resuscitation and start pressors early unless there was evidence of hypoperfusion, and then they could give boluses, versus the fluid liberal strategy addressed hypotension by additional fluid boluses before starting pressors. Between the two arms, ultimately, prior to randomization, in both the classic and the Clovers trial, both patient arms had about the same fluid, IV crystalloid fluid given prior to randomization, right at about 2 liters. And then ultimately, in both trials, there was a difference in that the fluid restricted arms got less fluid at all points than the liberal arms. Again, in both trials, as well as in the Clovers trial, as we would expect, given they started pressors early, those patients were on pressors for a longer amount of time and overall did receive more pressors in the fluid limited group early pressor interventions. So ultimately, what was shown is that whether it's the classics or the Clover trial, there was no significant difference in mortality in either the fluid limited versus the fluid liberal arms. As you can see here in the Kaplan-Meier curves and the overall outcomes data. But also importantly, there was no significant adverse outcomes that occurred either, including no evidence of hypoperfusion in the fluid limited strategies versus the fluid liberal strategies, including that there was no increased risk of renal hypoperfusion that led to increased adverse outcomes from a renal perspective. So while no improvement in liberal or restricted strategies for mortality, also does not appear that there is any improvement or risk of adverse outcomes in the fluid limited strategies of resuscitation. However, the question when you look at these is, are we really asking maybe the right question? And that is that when randomization occurred in both of these trials, there was no stroke volume assessment done. So we know that patients that would have been given the initial average of 2 liters of fluid at the time of randomization, there was no assessment for stroke volume responsiveness. So some patients that might benefit from additional volume loading would have been randomized to the fluid limited strategies. And some patients who were no longer fluid responsive or fluid refractory would have been randomized to the fluid liberal strategies. And so by definition, the randomization would have put these patients in categories that they were now getting treatment that they may not have benefited from either on the liberal or the fluid restricted side, instead of focusing on optimal care for each individual patient. And in a era of patient-centered care, stroke volume guided resuscitation for each patient will ultimately help us identify the patients that may benefit from a more fluid liberal or may benefit from a more fluid restricted strategy and early intervention with pressors, as opposed to a one-size-fits-all strategy. Because again, when we think back to our discussion from the meta-analysis from Cavallero, only about 50% of people giving fluid boluses are actually going to benefit. And so maybe a more patient-centered approach should be considered when initiating our early resuscitation strategies for our septic shock patients. So how can we address our fluid resuscitation in a patient-centered approach? Well, first, we need tools that will help tell us whether or not a patient is fluid responsive. And there, in general, are 3 broad categories. One, we could use static measures to assess for fluid responsiveness, such as the central venous pressure. But this is no better than the coin flip, and essentially that should not be considered as a good strategy for assessing for fluid responsiveness. We can use ultrasound-based tools. This day and age, we are certainly using a lot of more point-of-care ultrasound at the bedside for our critically ill patients, and we can discuss this a little bit further through the talk. Or we need stroke volume surrogates such as bioreactants or post-contour analysis devices that can give us immediate information about stroke volume and cardiac output of our critically ill patients. If we're going to look at stroke volume, there are 2 ways to tell us whether or not a patient is fluid responsive. We can look at stroke volume variabilities or pulse pressure variabilities called the variability indices. This is dependent on the heart-lung interaction on patients who are mechanically ventilated. And if the variability between the stroke volume or pulse pressure is at the beginning and end of respiration is greater than 12%, then those patients are considered fluid responsive. However, as we'll discuss, there are some limited applications across patient care of utilizing the variability indices. A more broad application is the utilization of checking whether there is an improvement in stroke volume after a volume challenge of greater than or equal to 10%. That's considered a positive response post-challenge. And this is independent of respiration on a ventilator or rhythm disturbances, as we'll discuss here in a minute, and therefore is far more applicable across multiple patient care venues. There are a multitude of devices out there that can give us information around stroke volume, and therefore, in some of them, they can give us the variability indices. But if you can measure stroke volume or cardiac output, and therefore stroke volume index, cardiac index, then you can assess for changes after fluid challenges. In terms of the variability indices, I just want to touch on that. These are very accurate, but only are accurate in certain patient care aspects. So this diagram is what is going on with the right and left ventricle with a breath. So this is the pressure time curve for a ventilated breath. So at the beginning of that ventilated breath, we increase pleural pressure and transpulmonary pressure. From a right ventricular standpoint, that breath will decrease right ventricular preload. And at the end of inspiration, the right ventricular stroke volume will be at its least, while the opposite is occurring for the left ventricle. During that breath, we increase left ventricular preload, and therefore at the end of inspiration, that left ventricular preload is at its maximum. And so the pulse pressure or stroke volume will be at its maximum at end inspiration. However, 3 to 4 beats later, that right ventricular low preload now is over in our left ventricle, and so we have minimal left ventricular preload and left ventricular stroke volume that then at end expiration, the stroke volume or pulse pressure will be at its minimum. Way to look at that is, again, our ventilator airway pressure time curves laid over our arterial line tracings, and our pulse pressure or stroke volume max will be at end inspiration, and our pulse pressure minimum will be at end expiration. And the variability of the differences between either pulse pressure or stroke volume greater than 12% would indicate these patients would be fluid responsive. However, as I've alluded to, in order for these variability indices to be accurate, multiple factors must be in place. First and foremost, the patient has to be on a ventilator and be ventilated at higher volumes of at least greater than or equal to 8 mils per kg. Passively ventilated, either paralyzed or significantly sedated so they are not assisting ventilation, be in a sinus rhythm, have compliant lungs, not be too tachypnic or too tachycardic so that their heart rate to respiratory rate ratio is greater than 3.6. How often does this actually occur in a ICU-based setting? This was looked at in a publication in 2013, in which in Europe they looked at 26 ICUs and found 311 patients that actually had devices in place for variability indices to be evaluated, either stroke volume variability or pulse pressure variability. And when you applied all of those factors that I just outlined there, only about 2% of the population of the 311 patient met all criteria. And over 70% of those patients were knocked out because they weren't mechanically ventilated or were assisting the ventilator on their own or did not have appropriate rhythms for variability indices to be assessed. So that is why the variability indices are not all that applicable across standard ICUs. Now, they could be used very well in ORs, where everything is far more controlled and paralyzed, etc. So that's why looking at changes in stroke volume after volume challenges is a far more applicable assessment for stroke volume or fluid responsiveness in our critically ill. So if we're going to do that, we need technology to do it, and then we need a challenge technique in order to assess for that change in stroke volume. The gold standard is giving a 250 to 500 mil bolus, but we will also talk about passive leg raise as a surrogate to that. 3 general technologies: bioreactants, Doppler-derived devices, or pulse contour analysis devices can give us the stroke volume to then assess for change. So in terms of passive leg raise, This is basically a reversible challenge of about 250 to 350 mils that occurs when you take a semi-recumbent patient, lay them flat, and elevate their legs to 45 degrees for about 1 to 3 minutes and reassess what the change in that stroke volume was. You do have to be cautious in doing this in certain patient populations, particularly those with labile hemodynamics or severe ventilatory insufficiency, at-risk airways. You should not do this in patients that are pregnant or have intra-abdominal processes with increased intra-abdominal pressure. This may be individuals with large volume ascites, intra-abdominal tumors, or other processes with intra-abdominal hypertension, because those would negatively impact fluid return during the passive leg raise process. Caballero did a meta-analysis looking at passive leg raise, and what they actually showed is that the area under the receiver operating curve is very high, and that using passive leg raise as a surrogate for fluid challenge to assess for changes in cardiac output or stroke volume had very high sensitivity and specificity, and that it was actually superior to looking at changes in arterial pulse pressure as a surrogate for improvement in stroke volume or cardiac output. And again, just a reminder that in this meta-analysis, there was almost 1,000 fluid challenges, and only 54% of individuals were actually fluid responsive with those challenges. So in terms of the technologies that we can use, bioreactance is a completely non-invasive technology in which you just need to take these electrodes, 4 electrodes on the patient's thorax. These electrodes pass a known current that is tiny into the thorax, and then reassesses what happens to that current in terms of the amplitude and how long it takes for it to get from A to B on the electrodes. That is plugged in, those changes in the current are plugged into a proprietary algorithm, and out comes a data on what is happening to that stroke volume. This data out of the bioreactance is accurate despite spontaneous breathing or patients on mechanical ventilation. The patients can be mobile, and it updates about every minute. In pulse contour analysis, these devices are hooked up to art lines that are in place, and the devices evaluate the systolic portion of the art line tracings. This area under the curve of the systolic portion is plugged into proprietary algorithms. In some devices, they need to be calibrated on a routine basis. In other devices, they are self-calibrating and take into account significant presumed constants in terms of vascular compliance, aortic impedance, and pulmonary vascular resistance. And then they pump out a stroke volume and or cardiac output. In terms of using the art line tracings, the more crisp that art line is, so avoiding over or under dampening, the more accurate these devices will be. Also, the more regular the pulse is, so not having tachyarrhythmias or AFib. As I spoke to earlier, we are using a lot more point-of-care ultrasound at the bedside these days, and therefore on the ultrasounds, we do have access to Doppler, and so we can assess for changes in stroke volume or cardiac output. Use of point-of-care ultrasound can be pluripotent in the evaluation of patients and assessing for perhaps the cause of the shock, reevaluating volume responsiveness or therapeutic interventions in the critically ill patient. However, it does take time, education, and repeated use to use these devices to assess for fluid responsiveness or resolution of shock and stroke volume or cardiac output. There can be significant inter and intra-observer variability in the data that comes out of them, how many devices you do have, and one other particular limitation is that these devices must be used by a provider and then go back and reevaluate by the provider, whereas bioreactants or pulse contour analysis devices can be used in nursing-driven protocols to assess for changes in hemodynamics and fluid resuscitation. So ultimately, what we hope to achieve with using these devices to assess for fluid responsiveness following fluid challenges or passive leg raises is to identify the patients who are actually fluid refractory, i.e., the patients that are not going to benefit from continued volume loading or resuscitation in their management of their septic shock. In doing so, we identify the patients that we can avoid giving excess fluids to that then could lead to higher morbidity or even mortality, perhaps, with excess volume, i.e., trying to limit that tissue edema in our fluid resuscitation of the shock patients. In those patients, we can recognize early and get vasopressors on board, titrate them as needed. We know that is safe and that perhaps earlier initiation of pressors in those patients that would benefit from them may actually improve outcomes as well. So is there any evidence that a stroke volume guided approach to fluid resuscitation in the septic patients is potentially beneficial? And the answer to that is yes. Our group did a retrospective analysis of our septic shock patients that presented to our ICU when we first had the bioreactance device in our institution. And then we retrospectively looked back at those patients and compared the patients that got stroke volume guided resuscitation versus usual care, which at that time would have been predominantly a lactic acid driven resuscitation, which was described in the literature at the time. And our hypothesis was that those receiving stroke volume guided resuscitation would ultimately have a lower fluid balance at certain times in the resuscitation versus the usual care group. It was exactly what we showed. So the blue line is the usual care group fluid balance over the course of 4 hours, 24 hours, 48 hours at the end of the ICU stay. And the red was the stroke volume guided group in which patients had a significantly less fluid balance at 24 hours, 48 hours, and at the end of the ICU stay. All of those in a multivariate analysis were also stroke volume guided resuscitation were independent predictors of having a lower fluid balance. Secondary outcomes were also found to be significant in our stroke volume guided resuscitation group. Particularly, they had a lower ICU length of stay, likely driven by the fact that less patients in the stroke volume guided group to a significant degree required mechanical ventilation, albeit the ones that required mechanical ventilation, there was no difference in the time that they required mechanical ventilation. About the same number of patients in both groups required vasopressors. However, those in the stroke volume guided group needed them for a significantly less amount of time, 32 versus 65 hours in the stroke volume group versus the fluid usual care group. And also, we found that patients were less likely to require acute hemodialysis, 6% versus 19% in the stroke volume guided group versus the usual care group. So stroke volume guided resuscitation was also deemed to be an independent predictor of a shorter ICU length of stay, need for mechanical ventilation, and shorter duration of need for vasopressors in the multivariate analysis component of our study. So these findings were impactful, and a dedicated prospective trial was completed by Dr. Douglas and colleagues in a multi-center study in the U.S. called FRESH, in which they recruited 124 patients and randomized them to either a stroke volume guided resuscitation protocol versus usual care in patients that had refractory shock despite 1 to 3 liters of crystalloid resuscitation. And these patients were all septic shock. Their fluid resuscitation assessments were via passive leg raise for stroke volume improvement, with a primary outcome that the patients in the stroke volume guided group were predicted to have a lower fluid balance, which was seen that they were about 1.4 liters less in the stroke volume guided group versus the usual care group. And additionally, some important secondary outcomes consistent with our study that patients in the stroke volume guided group were less likely to require acute hemodialysis and less likely to require mechanical ventilation. While not statistically significant, there was also a trend towards patients in the stroke volume guided group were higher, trended towards more likely to be discharged home versus those in the usual care group. So ultimately, in stroke volume guided resuscitation in patients with septic shock, important outcomes in terms of renal dysfunction and need for acute hemodialysis, as well as less likely to require mechanical ventilation. Certainly important secondary outcomes, even if there wasn't findings of changes in mortality. So in the FRESH trial, what this did show us was that a passive leg raise guided stroke volume resuscitation to assess for fluid responsiveness in our patients with septic shock was safe, led to lower net fluid balance and a lower need for mechanical ventilation and renal failure, and thus supporting that the use of dynamic assessment for fluid resuscitation is an important way by which we can resuscitate patients. And this trial was an impactful trial that did change the 30 mils that led to that reducing of the 30 mils per kg component being reduced to a week recommendation with low quality evidence, and that perhaps a more objective approach to our resuscitation of patients may be a better way to resuscitate our patients if we have the technology in our facilities to use it. But what I'd like to do in the last few minutes is actually go through a few patients here that we have looked at stroke volume guided resuscitation as they present to us in our medical ICU. These are all real patients that I've taken care of over the years. So AR, she is a 72-year-old, 80-kilogram woman who was admitted from her skilled nursing facility with a 1-day history of altered mental status and fevers. She's hypotensive on presentation with evidence of a UTI from an indwelling Foley. She has a history of ischemic cardiomyopathy with a baseline EF around 20% and chronic renal failure with a baseline creatinine of 3.5. In the ED, our colleagues gave her 500 ml bolus of fluid and appropriate antibiotics, and then called us about admitting her to the ICU. They were hesitant to give any additional fluids because of her increased O2 needs from baseline, as well as she looked volume overloaded. So when she arrived to us in the ICU, she was febrile at 39. She still had a blood pressure of 80/40. She was tachycardic and normal sinus rhythm at 95 and tachypnic at 28. Her O2 requirements were at 6 liters, which was above her baseline of 2. We did confirm via point-of-care ultrasound that she did have a reduced LV function, but there was no pericardial or pleural effusions. There were no B lines and no evidence of pneumothorax as a contributing factor to her shock or hypoxemia. The POCUS did demonstrate that she had dilated IVC, which is also why our ER colleagues were hesitant about giving her any more fluid than that initial 500 mils. However, we had our bioreactance device that we hooked up to her, and we assessed her for fluid responsiveness. We did a passive leg raise, and she had a 15% improvement in stroke volume. So therefore, we gave her a 500 ml bolus, also demonstrated a 16% improvement in that stroke volume. We gave her another 500 ml bolus and only had a 7% improvement in her stroke volume. So we stopped resuscitation and initiated her on norepi to improve her MAP to greater than a 65, which took about 0.08 micrograms per kilo per minute. About 3 hours later, our team was notified of nursing that they had titrated up her norepi dose to 0.15. With that increase, we wanted to reassess whether or not she would still be fluid responsive. So again, we did a passive leg raise and saw a 20% improvement in her stroke volume. So we gave her another 500 ml bolus at that time. This resulted in a 22% improvement in her stroke volume. We gave her another 500 mils. It was an 18% improvement. Another 500 mils led to a 12% improvement, and a 500 mils only resulted in a 6% improvement. And what we saw over that course of time, our norepi dose did decrease to 0.06 mics per kilo per minute. And over the course of the next evening, ultimately, her pressors were able to taper off. We did get a positive urine culture to a sensitive organism, and her O2 requirements also improved back to her baseline, and her urine output improved and stabilized, and her creatinine returned to its baseline over a 48-hour period. So this is a lady with known cardiac disease, known renal dysfunction, who appropriately people are going to be very hesitant about giving fluid. However, with fluid resuscitation guided by bioreactants, we were able to give an additional 2.5 liters of fluid appropriately. And ultimately, I believe she got better because she got the right amount of fluid and the right amount of pressors to help her through her septic shock. Our next patient is a patient who presented with septic shock and cirrhosis. We are a pretty large liver transplant center, so we have a lot of cirrhotic patients that we care for. As you all know, these patients can be very difficult to assess their volume status. This particular patient, KB53, with end-stage alcoholic cirrhosis, complicated by large volume ascites requiring weekly to every other week paracenteses, presented with a 2-day history of progressive encephalopathy and weakness. In our ED, she was hypothermic, only oriented to self, and had some generalized abdominal pain. She was tachycardic and hypotensive on presentation, and a little tachypnic at 26, but room air. She had some significant laboratory derangement with hyponatremia. She had an acidosis with a metabolic a bicarb of 15. Her creatinine was 1.5, and her lactate was 4.2. She was given 30 mils per kg of LR and appropriate broad-spectrum antibiotics. Post-fluid resuscitation with that 30 mils per kg, she was still tachycardic at 105 and borderline hypotensive at 85/48. Our team was consulted for admitting her to the ICU, which we did. In the ICU, we did a paracentesis. Actually, our ED colleagues did that, and it was consistent with SBP as a source of infection. She was also given 1.5 grams per kilo of albumin per SBP protocol. Despite that and the initial fluids, she was still borderline hypotensive at 90/40 with a MAP of 57. The question is, does she need more fluids or does she just need pressors? Again, these patients are very difficult to know in the chronic vasodilatory state of cirrhosis, but also chronic volume overload. Her urine lights were assessed that demonstrate evidence of either hypovolemia or hepatorenal syndrome. So we wanted to assess what her stroke volume was. We hooked up our bioreactants device. We could not do a passive leg raise due to her tense ascites. Her stroke volume index was at the upper limits of normal at 58 mils per meter squared. We went ahead and started norepi and titrated to a MAP greater than 70 per our protocol for renal failure in our cirrhotics. And her stroke volume index only improved to about 60. So we did not give her any more fluids and just titrated our norepi. And over the course of the rest of that 24 hours, her hemodynamics improved, her shock resolved, and her norepi was able to be titrated down and off. Her renal function also improved. So again, utilization of stroke volume assessment in that particular patient, that's difficult to assess. Do they need pressors or do they need fluid? Was helpful in knowing what that stroke volume was in that patient. Our last patient that we'll discuss presented with some undifferentiated shock from an outside facility where he had been for several days and was progressively declining in terms of shock and respiratory failure. So this patient is a 32-year-old, no significant past medical history, had been at an outside facility for several days with progressive multi-organ system failure of unclear etiology, without any clear evidence of an active infection or other precipitating cause to his multi-organ system failure. Upon arrival to our facility, he required immediate intubation, as well as very rapidly progressive severe shock that was refractory to multiple vasopressors and a severe metabolic mixed acidosis, where we immediately had to initiate emergent CRRT for treatment of his metabolic derangements and severe acidosis. He was very tachycardic and was in sinus rhythm and hypotensive despite multiple pressors. He had diffuse anasarca and was warm throughout. We assessed his stroke volume by again hooking him up to our bioreactance device. His stroke volume index was very low, pre-passive leg raise at 25. After passive leg raise, it actually declined to 22 with a negative decline of about 12%. There is some retrospective evidence that a decline in stroke volume index may indicate a significant cardiomyopathy. We then did POCUS and got an official echocardiogram that confirmed the stroke volume index did correlate with a reduced cardiac index. So we did POCUS and a dedicated echocardiogram that did confirm that he had a significant dilated cardiomyopathy, just overall global hypokinesis with reduced EF of about 20%. This patient ultimately progressed to 5-pressor shock within 5 hours of arrival, with unclear etiology of his decompensated cardiogenic shock. Ultimately, additional evaluation led us to, and history from family and a roommate that called in to check on him, that he was kind of a closet alcoholic, and this was a wet berry, and he was aggressively given high-dose IV thiamine, and thankfully, over the course of the next 24 hours, he had significant improvement and ultimately recovered from his multi-organ system failure and was discharged to an inpatient rehab 1 week after presentation to us. But again, assessment of his stroke volume to identify his significant cardiomyopathy and further assessment was very important to his diagnosis, treatment, and ultimately recovery. So in closing, there's mounting evidence that we can cause harm in our patients presenting with critical illness and shock, and specifically septic shock, by over-resuscitating them and excess fluid status, both in terms of mortality as well as potential for negative secondary outcomes, whereas utilizing technology such as bioreactants to guide our fluid resuscitation via stroke volume assessment could lead to overall less risk of negative secondary outcomes, particularly negative renal outcomes, which can lead to negative impact to long-term mortality. One of the highest predictors of negative outcomes and one-year mortality is development of acute renal failure in an ICU setting. We can focus on early and optimal fluid resuscitation via these dynamic indices to help prevent late fluid and volume overload in hopes of optimizing the care and outcomes of our patients. Certainly, we do and would benefit from additional prospective randomized controlled trials, specifically looking at whether or not initial stroke volume guided resuscitation, even before or at time of presentation, to further challenge the 30 mils per kg would be very beneficial. And I'm hopeful that something like this does occur in the near future. But consideration of stroke volume guided resuscitation in our patients where these resources are needed may be in fact impactful to our patients who present with a septic shock. Oftentimes people say, which side of the fence am I on? And I do come from a rural part of Kansas where I will say they don't necessarily have the technology to do stroke volume guided resuscitation. And if one of my parents presents to the local hospital there in severe sepsis and septic shock, my hope is that they'll give them appropriate antibiotics and appropriate 30 mils per kg as soon as possible, and then assess if they need pressors and to get out of that facility to a high level of care. But if my parents are visiting me in Kansas City and they develop septic shock and we bring them to our hospital, I hope they're resuscitated by stroke volume guided resuscitation to give them the absolute right amount of fluid and not one drop more, and then initiate pressors if that's the case. So I think both can be true depending on what the resources are for the facilities. But for resource-rich facilities, I do think that a stroke volume guided approach gives us the best option for our patients in an individualized approach to the patient care in optimizing care for the patients with septic shock. Thank you very much, and I hope this has been helpful for everybody that got to watch it.